Hey folks, Scott Weingart here, and this is an EMCrit We. So in the JAMA, a trial was recently published called the HAPPEN trial. It was for non-invasive positive pressure in COPD. And I think it's kind of inexplicable it was published in the JAMA, but I think it's going to be a big trial in terms of people speaking about it. So I wanted to get a take out there on EMCrit, and there's no better people to discuss this with than my partner in crime on EMCrit, Josh Farkas of the PulmCrit blog and the Internet Book of Critical Care, and then Alexander Bracey, head of ED Critical Care at the Albany Medical Center and aficionado of all things resuscitative non-invasive positive pressure ventilation. So the three of us spoke about this trial. I'll do a quick pico. You can check out the trial and read it yourself for further details. But basically, they took patients who were COPD, and as you'll hear in the discussion, I'm not quite sure what you name this group, because they're not the encephalopathic hypercapnic patients, nor are they the patients in severe distress that you'd be like, maybe I should intubate this patient if this non-invasive doesn't work. They're kind of this middle group. Their pH was less than 7.35. Their PaCO2 was greater than 45. They were put on non-invasive for 6 hours at normal non-invasive settings. And then if they still had a PaCO2 of greater than 45, they were randomized to one of two groups. They were either put in a high-intensity non-invasive group, which was shooting for a tidal volume of 10 to 15 mLs per kg. And in order to do that, they'd keep increasing the IPAP up to a maximum of 30 centimeters of water. And then there was a quote-unquote normal group. Comparison group was shooting for a tidal volume 6 to 10 mLs per kg, and they could go up to an IPAP max of 20. And they were attempting, inexplicably, to get absolute normalization of PaCO2. And I mean absolute as in not the patient's normal, calculating with their bicarb where you expect them to be, but like normal you and I PaCO2s, like a PaCO2 of 40, which to me is crazy, but hey, that's what this study went with. And if they couldn't get that, they'd keep upping the doses. They left these patients on BiPAP for extended periods of time, like 72 hours, and they were not in ICUs. Again, pointing to, I don't quite understand this group of patients. They were in non-ICU wards. And the primary outcome of the study was predetermined criteria for intubation. Not the intubation itself, but did they meet criteria for intubation? And the criteria for intubation I've listed in the show notes for this episode, but it's all the normal stuff you'd expect, like cardiac arrest, severe respiratory failure, etc., low P to F ratio. But there was also other arbitrary stuff in there. So you can check it out. But so based on that criteria, it was a positive trial. Far less patients had met the criteria for intubation in the high intensity group. Now, in terms of actually getting intubated, the real patient-important outcome, no difference between the two groups. Now, the authors said the reason that is because the low-intensity group was allowed to cross over to high-intensity, and many did. And as a result, they clearly would have been intubated if not allowed to cross over to high-intensity in the minds of the authors. And that's why the intubation rates were the same, even though the primary outcome allegedly was a positive. All right, obviously, you could tell by the way I'm stating this, I am not an enormous fan of this study for its outcome. But as you'll hear, I think it's a very important trial for the safety of extending your range of safe IPAP pressures for patients with COPD. But there's no need for further introduction of the trial. Let's just get into the discussion. And then if you have additional thoughts or comments, you could put them in the comments section of this episode, and then I will endeavor to answer them. All right, with that, let's get to Josh, Alex, and I talking about the HAPPEN trial. So, Bracey brought this trial to my attention, eventually would have bubbled up. Bracey seemed excited about it. I, upon reading it, less so. How this goes. Yeah, why don't we start off with just general gestalt feelings about this study? Alex, and I'll do the little pico in post, so we don't have to do that now. Alex, how do you feel about this study?
Yeah, you're totally right to point out that I initially was like, yes, this is exactly what I'd been waiting for. So glad to see that they're doing this kind of a study and demonstrating that this can be done with higher pressures in patients with COPD and having improved outcomes. The sticker shock was there for me. And then upon reading it in a scrutinizing sort of way, my enthusiasm is tempered, but not totally gone. I'll say that.
All right. So a slightly positive assessment. Josh.
I must admit, I really like this trial. I agree that it has a ton of methodological limitations, but I think this has been like a black box for me for a long time. We sometimes get these patients, you put them on BiPAP. They're not like crashing and burning. They're not really getting better. They're just stuck there. And then the question is, should you crank up the BiPAP or just give up and intubate them? And I must admit, my practice has increasingly been just to crank the BiPAP up. And it's basically, I've had good results with it, but I always felt dirty about it. Like I was doing something creepy. And maybe if I increased the pressure too high, the patient was going to aspirate or turn into a balloon. So I could study, because I think this supports the fact that if you feel like that's clinically indicated, you can go ahead and do that.
All right. So 2 positive. I'm going to be the negative dissenter and it's the same case as so many of these COPD non-invasive trials, which is, first of all, I'm not able to picture in my mind what group this therapy is for. And so maybe that will lead us in then to our first question, which is, in my mind, there's 2 groups in COPD that I use non-invasive for. There's the COPD exacerbation where they're having some form of bronchoconstriction and dyspnea. And then there are the patients who are obtunded or frankly comatose with profound hypercapnia. And these patients, and it's this study and the most recent COPD trial as well for non-invasive, I don't understand. It's certainly not the latter group. They're not obtunded from hypercapnia. So I have to guess they're on non-invasive because they're in the former group, but they don't seem to be in particular severe respiratory distress at the time of randomization into this trial. So I guess that's my first question to you two. What are we treating here? Are we treating a number? Their pHs weren't that impressive. What is the treatment that you think this new modality is offering?
Yeah, I guess I'll just jump in real quick. I think I totally hear what you're saying, and like I have a particular obsession, and like I look out for stuff for the group that you're describing, which is the comatose hypercapnic encephalopath, and I totally agree. That's clearly not, at least at the start of the study, it's not the group that they're interested in. But it's also not people seemingly who come in for, hey, I've got like a little tightness in my chest and a cough and like maybe some increased sputum production. I think they're the people who come in respiratory distress but don't have severe features beyond increased work of breathing that this is describing, and maybe prevents them from going on to have the more severe features, hypercapnic encephalopathy and the like. So I think in my mind, while I was reading this anyway, I'm applying this to the middling person who probably needs to be seen immediately, but doesn't need, no one in the room is going to be like, hey, this person, should we tube this person? And you're like, no, I want to try a higher setting of BiPAP first. I don't know. Do you think otherwise, Josh?
I agree. I think one huge challenge with a lot of non-invasive trials is every center uses this differently, and we're all applying it to different patients. So it is challenging. If you're doing an RCT of like Tylenol, 1,000 milligrams of Tylenol in the United States and 1,000 milligrams of Tylenol in China are the same thing. But there are some strange things about their inclusion criteria, and like they were using BiPAP for like multiple days, which is something that I typically do not do. And so I think like the overall context is a little different. And honestly, it's hard for me to know exactly what they were doing with the BiPAP therapy here. I think one important thing to note is that they only included patients who were on BiPAP for 6 hours. And I think that's an important thing to recognize. So that's basically like sift out all of your crashing and burning patients and all of your patients who are unable to tolerate BiPAP.
Absolutely. And we could go a step further and say, because this multi-day thing, I think, is a hugely important point, is I don't know what their end goals were for these patients, because I don't know about you, Josh, but 24 hours is generally the non-invasive run for most of my COPDers. Are you guys doing multi-day? Josh, at your ICU?
Very rarely. I agree with you. I think 24 hours of BiPAP is generally plenty to rest the patient and improve the CO2. I think there are a group of patients with like very severe disease where I might put them on BiPAP for 24 hours, then take them off during the day and leave them on nocturnal BiPAP. Yep. But to have someone on a 3-day run where they're on BiPAP for most of the time during those 3 days, I think that's a lot more than I would generally be doing. And it does speak to the fact that they had like there were some patients who were getting nasal ulcerations and stuff. So I think the outcomes and the goals of BiPAP in this paper were maybe a little unusual.
And it seemed like they're looking to normalize CO2. There wasn't this thing of the patient's normal CO2 based on their bicarb retention. And yeah, of course, I don't think you're going to win on my strategy of non-invasive if you're trying to normalize a longstanding COPDer's CO2 level. And that was the thing that just said, what the hell are they trying to do here? And then I guess the next question is, how deeply did you guys delve into what their actual strategy was? Because we agree that if there is a CO2 goal you have, and if your non-invasive is not meeting it, then you need to increase the minute ventilation. That seems like a reasonable assumption. Now, they opted to do that by increasing tidal volume, but they didn't even have these patients on rates. These patients were on spontaneous non-invasive with a backup rate of 12. Now, that just seems counterintuitive. Why wouldn't you, if you wanted to increase the minute ventilation, pick a reasonable tidal volume? And look, I'm happy to go to 10 on these patients if they don't actually have signs of lung injury, and then just increase their respiratory rates. And that was completely ignored in this trial. The concept of mandatory minute ventilation, or your favorite mode, Bracy, which I'll let you talk about shortly. So why, if we had to put our minds in the clinicians in this study, why are they doing it by tidal volume?
Yeah, if I could take a stab at that, why are they doing it? They do comment on that particular thing in a very positive way, actually, in the discussion section. They're like, and look how we have no instances of auto feeping and breath stacking. And probably we did that because that was the case because we didn't set a rate. But I agree with you. Normally, my first move is to increase the respiratory rate in order to increase minute ventilation in this. That said, again, one of the pluses for this trial for me is that I have a fair number of patients where I'm like, okay, I'm not getting where I need to go. They're taking tidal volumes of 250 and they're, a 6-foot adult. I'm already at my previous limit of an IPAP of 20 or, a tidal volume from using AVAPs, as you so kindly led me into, for, that's about 9 cc's per kg of ideal body weight. And it's not getting where I need to go, so I'll increase the respiratory rate. And very often those patients, anecdotally anyway, don't do particularly well. They don't get what they need. And I feel like I end up intubating a fair number of them. Admittedly, as you pointed out at the start, a lot of those are not the patient that we're describing. They're not somebody who's like awake and being like, I've got some shortness of breath in your resus room or otherwise. I'm usually trying to get those volumes on somebody who's altered or fully encephalopathic. So I agree. It's not necessarily the right population to apply, or in the one that I would have loved to see this applied to. But I would guess that they were trying to address the problem of we can't get enough tidal volume, or getting pitiful tidal volumes on these hypercapnic patients, rather than the people who have a rate problem. That would be my guess.
I want to come back to that, but I want to hear what Josh has to say first before I hit those points.
I do think that the concept of shooting for a higher tidal volume may have a lot of physiological rationale to it. So when you think about it, first of all, when you put on the BiPAP mask, you're adding dead space. And then additionally, patients with bad COPD have elevated dead space to begin with due to alveolar destruction. And there's some evidence in CPAT world in trying to look at the amount of dead space in these patients. It can actually be very substantial. I think that there may be a reasonable rationale to say, if the patient isn't clearing enough CO2, when you're putting in like a 500 cc tidal volume, they may only be getting like 150 or 200 cc's minute ventilation, alveolar ventilation from that. And they're doing a lot of work of breathing and they're like wasting a lot of energy there. If you can just increase it by 200, you're probably like doubling your alveolar ventilation. I kind of do like that concept that maybe some of these patients with really bad emphysema and really elevated dead space just need bigger tidal volumes.
I think that's fair. And to hit your point, Bracy, I think you blended two things in your answer just now, right? Because you said you had an arbitrary IPAP limit and you weren't making it with just respiratory rate, and you wanted to have the ability to increase the IPAP because, and what goes along with Josh's point too, is that maybe they did have so much dead space, it just wasn't happening. I don't think you have to take this entire package as one, right? If this study allowed you to liberalize IPAP all the way up to the 30 they did, I think that's perfectly.
Hey folks, but we're not getting right to the show because
You're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Fair, and no reason for me to say that's not safe. But they were searching for tidal volumes 10 to 15, which, when the point you were making, you didn't need to get them to a tidal volume of 14 and have that as your necessity for increasing your IPAP. You were telling me just now you had a patient who was only getting 200 tidal volume and you stopped at an IPAP of 20. By all means, go to an IPAP of 25, go to an IPAP of 30 to get the tidal volume you want. And like I said, I'm all for liberalizing all the way up to 10. We have data for that in even patients with mild lung injury from the Provent or Prevent? Josh, you're the...
Prevent, yeah, Prevent. That's the Dutch one, right?
Yeah. Okay, thank you.
They were double year for Prevent trials, I think.
Yes. And so that's cool. I just don't understand arbitrarily pushing them to above 10 tidal volume, though, Josh, your point is well taken. Maybe the reason is that they're not actually getting anywhere near that. So that's fair. I guess where I'd like to go next is what you guys feel at the bedside will be your new baseline strategy after this study, and whether that's a change from where you were before. Or is this just something now you have in your back pocket for special cases? Why don't we start with you, Josh?
I don't think this will affect my initial strategy. The fact of the matter is the vast majority of patients with COPD exacerbation, they come in, we put them on BiPAP, we give them bronchodilators, they do great. And I think most patients will do fine with just kind of basic stuff, and exactly how you titrate the BiPAP doesn't super matter. But I think there is this group of patients where, 2 to 4 hours into it, I'm thinking more here of the somnolent, encephalopathic, hypercapnic patients where they're just not really getting better. And you go to the bedside and their tidal volumes aren't that great. I think this will be evidence that it's safe to be more aggressive with those patients and to increase the inspiratory pressure, and you're not going to see some sort of horrible aspiration event. And on the flip side, it's interesting digging back. I think traditionally there was this concept that like intubation was always the way to go. And if you're ever worried about intubating a patient or securing the airway, you should always err on the side of intubation. But like when you think about the peri-intubation complications, ventilator-associated pneumonia, delirium, deconditioning, there's a lot of bad things that happen to these patients when we intubate them. So I think this study supports the concept that I think it's safe and reasonable in these patients to continue the non-invasive therapy, shoot for higher pressures, try to avoid intubation.
And what mode are you starting them in? Because I think for Alex and I, they might have an initial trial, the conventional S&T mode, but then AVAPS is pretty much very rapidly the change we would make. And then you're dialing in a tidal volume. And with a liberalized IPAP range, you could pretty much get whatever tidal volume you want. So are you ever using AVAPS, Josh? And if you are, what is your goal tidal volume in these patients?
Yeah, so I'm basically just using the standard ST BiPAP setting and just looking at the tidal volume and adjusting the pressures to roughly gauge the tidal volume. For most of my patients, we're not really using a lot of a backup rate. We're largely relying on their spontaneous respiratory rate. Occasionally, there are some patients where I'll use a backup rate, but I must admit, it does weird me out a little bit. It just makes me a little nervous that maybe there's like an increased aspiration risk, or I might be going a little bit too far when I'm really just like initiating machine breaths on them.
All right. Alex.
Yeah, my big takeaways for this are like more of a general feeling for, my thought usually and almost always comes back down to the emergency department setting. And so in the general sense, it's supportive of a lot of what I have suspected a lot, I think, which is that we should not be starting these patients that have COPD exacerbations on 10 over 5. That's probably not contentious at all. But like even the low end group, like their initial settings were like 17
an IPAP of 17 or 18 or so. So should be, I think, from the jump doing that on COPD exacerbation patients in the ED setting. I think that's an easy statement to make, and one that I feel good recommending to all comers going forward. On a personal level, it is supportive of if I feel like I'm not getting where I need to go, and the more encephalopathic the patient, the more this will apply to. I'm not getting where I want to go with 20 centimeters of water as my prior IPAP limit. I will probably go higher. I don't know where I'll end, but certainly below 30. But I'm still a little apprehensive about the rates of abdominal insufflation in this study. I feel like maybe a person in the ICU after 6 hours at a minimum has some time to digest food or something. But whereas every ED patient ever is like Big Mac just before they come in, and that's what triggered their COPD exacerbation. So I'm a little leery about that to go much more aggressive, certainly as a general recommendation. But I think I will probably with very close monitoring go higher when it's my patients that I'm interacting with, and I'm like being very aggressive about closely monitoring. And then the last thing is, again, in a general sense, I think that, as Josh was saying, this kind of the prevailing wisdom often is like, hey, if you can't get where you're going to go on this shift, or before the patient goes up to the ICU with regards to neurocapnia or being able to take them off the BiPAP, maybe you should probably tube that person. And I think that maybe this is empowering you. And I'll take a step back before going further. We know that intubating these patients often, at least on like a Cochrane level review, it has mortality influence. And so if we can prevent, that's awesome. And maybe this liberalizes our ability to say, hey, we haven't gotten where we want to go with the BiPAP in the short trial they have in the ED, and they're on their way up to the ICU. Maybe we actually can just transport them on the BiPAP and not have tube every one of these patients to seem as though we're taking optimal care. Maybe, and I think they demonstrated a long-term safetiness to, if that's a word, which is not, to using non-invasive in these patients. I think that is another general position to be able to take.
Alex, are you still AVAPs, or are you going to go with S&T for study?
Again, it's just the ED mindset and setting. And it's like, sometimes I'm privileged enough to be able to like dedicate a lot of time to one patient, but most of the time I get pulled away like within minutes of setting the parameters on the vent. So I'm still AVAPs all the way, because it really is just not possible to circle back on these patients the number of times you need to without it. And as you correctly pointed out, I think they take a turn onto their left side, and now the volumes are different with the spontaneous time setting. Yeah, AVAPs is, I just think that the setting for the ED.
Let's talk about some of the safety issues here. So auto-PEEP, it's silly they even mention it if they don't have the patient on a mandatory rate. The patient can't get auto-PEEP. They're going to have as long an exhalation time as they want. The absence of ventilator-induced lung injury or non-invasive induced lung injury, they have no ability to monitor. They made that conclusion from the absence of pneumothoraces. So I'd still be a little leery. This trial certainly doesn't tell us that these tidal volumes that we know, like this would be going back to, albeit non-invasively, though I don't think the lungs care, to an era before our seminal ARDS study, right? So how are we okay with that? And why are we okay with that?
So one question I would have is, how accurate do we really think these tidal volumes are measuring? Like if someone's intubated, I feel pretty confident that the tidal volume is what the tidal volume is. But if someone is on a BiPAP mask with like 20% leak and some sort of leak compensation, is that like really an accurate number?
You've engendered the answer by the question, right? Yes, if they have the 20% leak, we have some inaccuracies. Most of my patients, I don't know, maybe their faces are just more standardized, but I don't generally have enormous leaks on my well-fitted BiPAP mask. And the masks have gotten a lot better here, at least if the hospitals are stocking anything recent. So I don't know. I throw the question back to you. Do you not believe the tidal volumes if the patient doesn't have any clinically apparent leak? Forget about what the ventilator says in terms of leak. When I look at that mask and it's just like solid, nothing's coming out. Yeah, I pretty much trust those tidal volumes.
I don't know. I personally think they might be like overestimating things a little bit. And I don't know, maybe I don't have a lot to base that on.
All right, let's take as a given that on a particular patient in front of you, it is accurately measuring. Are you all of a sudden now comfortable with 14 mLs per kg tidal volumes when every other piece of literature has told us that was what they used to do and it's anathema?
The ARMOR trial looked at patients with ARDS. So clearly, if you have lung injury, that's a bad tidal volume. I think the question would be, if you have someone without parenchymal lung injury who has COPD exacerbation, is that dangerous or not. And I'm not sure that there's super evidence certainly for this group of patients. I think there's some evidence for intubated patients in the OR, but that's largely correlative. So I think the only super high quality evidence that we have that large tidal volumes are harmful is from the ARMA trial. And this is like a completely different group of patients.
I'll let Alex respond, and then I'll retort that.
Well, I feel like the study that I would have quoted you already mentioned, which would have been Prevent, which again, they went up to about 10 cc's per kg of ideal body weight, and it didn't show any meaningful difference. To come back to, are the tidal volumes even accurate? There's very clearly a percentage of pressure that is going into the stomach in these. So it's hard to guarantee definitely where these things are going, even with a tight seal. But to answer directly your question, would I be comfortable with somebody at 14 cc's per kg? I think maybe for a spell, if that was the difference between, if I really felt that I was going to win in the next hour or so, I might try it, especially the less desirable the airway to be taken, the more likely I would do it, but probably for short spells. One other thing about this, though, just in general, is that they commented on a lot of patient factors. It's totally possible that I missed it, but I didn't see obesity as a patient factor here, which is probably demonstrative of their milieu. But the more obese a patient gets, I think I'm likelier to do higher volumes because of the offsetting external chest wall forces. I don't know. Does that resonate with you guys?
I don't know. You're still conflating volume and pressure for me, Alex. Yes, I want to liberalize my pressure, but I don't want to liberalize my tidal volumes in even obese patients. It just takes a lot more to get to that tidal volume. Josh, to your point, and I wish I had the study on the top of my mind. I'll have to pull it up. But there was a pretty well-wrought study that demonstrated a greater progression to lung injury in patients who had higher tidal volumes and not lung protective. And I'll have to pull it up. But I just feel like based on that, the logic you guys have just demonstrated, it's okay, when we have those aspirin toxicities, why aren't we putting those guys at 14 cc's tidal volume per kilogram? Because after all, they don't even have they don't have anything wrong with their lungs. Why are we not doing that? Maybe you guys are, but it would be a very big shock to me if all of a sudden, I feel like I'm somehow breaking taboo when I tell people go up to 10 cc's tidal volume on these patients who have a metabolic acidosis with no significant lung injury. They're like, what? I could go up to 10? I'm like, yeah, until you get the acidosis done, you can. Now, all of a sudden, you two are saying I should go up to 15 on those patients. Is that right?
If you had a non-intubated aspirin toxicity patient who's goosebump breathing and you could measure their tidal volumes, I'd bet you they're like 14 or 15 cc's per kg, just all on their own.
I don't know if that's a perfectly apt comparison, as what we take in negative inspiratory-wise is not the same as what we put in positive inspiratory pressure-wise.
But to get back to your question, though, I think this is like the quintessential challenge of like critical care medicine. And I think about this a lot when I think about like intermediate risk PE patients. Like no matter what we do, there's going to be a risk. There's no zero risk way out of this situation. So we're really just trying to assess risk and minimize risk. On the intubate arm of things, I think you can be pretty confident that there's a mortality risk involved in intubation and a VAP risk involved in intubation. Those risks, I think, are well delineated in the literature and strongly evidence-based. As far as the tidal volume, I agree with you. There is a theoretical concern, absolutely. And I'm being a little bit of a devil's advocate here. It doesn't make me feel warm and fuzzy to have someone on a 14 cc per kilo tidal volume. But at the same time, has that risk really been proven in an evidence-based way? I don't know.
That's fair, but I really want to pin you down because you avoided the question. Based on your logic, should I take a metabolic acidosis patient without lung injury and put them on 15 mLs per kg?
I think that would be fine if that was necessary to stabilize their physiology and get the pH up and avoid aspirin getting into their brain. I think for a short period of time, that would be fine. We've all been in situations like this where like you intubate a patient with like horrific metabolic acidosis and the patient's dying and they're on a ton of pressors and they're bicarbonate too. And you just crank the ventilator as hard as you can. And it's not great, but you just do it.
See, it's funny. I've been cranking it to 10, feeling like I'm a bad boy. And I'm not disagreeing with you. This is like eye-opening. Alex, are you doing the same?
I totally piggyback on the idea of short trial. Like I said, I think for me, it would be a very time-based thing. I'm not saying I'm sending these patients up to the ICU on 14 cc's per kg from the ED. No way. In fact, I'm not handing this off to anybody. This is like my person. I'm staying in the room with them. But I think if it was the difference between intubating a patient and I felt that an hour might get them where they were going, I think I would do it.
What haven't we hit that you guys think is important about this trial?
I have a question that it's totally out of my purview because I don't see these patients upstairs, but it comes back to one of the things we originally talked about, which was a 24-hour period. I just found Brian right. He was like, how do people eat on BiPAP upstairs when they're like, that was the crux of the question. So I'll put that back to you both, please, is how at 72 hours, there's essentially like the terminus of this trial. Like, how would that work logically? Does it, or is it, I just don't get the mechanics of it.
I'm going to give my ignorant impression, and then we'll hear the erudite impression from Josh. But that's another point of this trial, is they're obviously taking breaks for water, for eating, for all that stuff, which means I don't think you're that fucking sick. Again, go back to where I started. I don't understand the inclusion group for this study, and therefore I can't evaluate the results. But Josh, you tell me where I'm wrong.
No, I agree with you. I think they were using BiPAP in a frankly incredibly aggressive and almost like unnecessarily aggressive fashion. Like they were having patients with respiratory alkalosis on a BiPAP. I've never encountered that in my entire practice. So I feel like I agree with you. I think they were using BiPAP in a super aggressive way, which is different from the way that I would use it. But I think the safety data is still somewhat reassuring. As far as
no one popped their lungs. That was good. We have that. No one puked from their high BiPAP setting. That's good. So I completely agree. If nothing else, this trial gave us a beautiful backstop on the safety side for everything except long-term lung injury. We don't have that, but we've already made those points. All right. Anything else you guys want to talk about?
Super fast, with just to piggyback off of that last little section here, is that there's one major element that I think that influences this study that we haven't mentioned yet, and that's that this study occurred during the pandemic, like the literal timeline of the worst of the pandemic in China. And so that it was stopped early, partially for demonstration of improvement, but also they go out of their way to say also because it was logistically very difficult. So that puts another kind of major asterisk on this study itself, just in terms of the conclusions and the like. But
that's a great point. And it just brought to mind another point that I should have made, but I didn't, which is this was a negative trial. Like we haven't commented on that. Their primary outcome was negative in terms of, in my mind. Now, yes, the way they wrote the paper, it's a positive primary outcome because, and I should be clear, intubation was no different between the two groups. But the milieu, to use a word Alex has just used shortly before, of it was one in which intubation might have happened in some world by which the study was followed. And so the need for intubation was different, but by their pre-specified criteria. And I disagree with their criteria as a need for intubation. So that didn't blow my socks away. And the reason why these patients were able to avoid intubation in their mind is they were crossed over to the high intensity therapy group. And with the leading suggestion that if they weren't crossed over, they surely would have been intubated. But in my mind, like the real patient important outcome, intubation, was negative. Does that temper your enthusiasm at all?
Yeah, I would agree. I think like the conclusions from this trial, so I've been kind to it, but there are like a lot of major problems methodologically. First of all, I completely agree with you. The outcome was like this theoretical indication for intubation, but the actual intubation rates were the same. It was an open label trial, which I think is unavoidable, but it is something. Patients in the intensive group received therapy for longer. So there's like a whole host of limitations.
Alex, does that change your feelings at all?
It's not that I think going back to what I can take away from this, which is really safety, and then also like mindset, it doesn't make me feel one way or the other. From the emergency medicine vantage, again, like that start your pressures higher, maybe not to the moon, and maybe a trial of higher pressures is indicated where if you don't get where you're going, obviously use AVAPs, and then again maybe tee up our ICU colleagues for these patients who are otherwise awake and middling. Just give them a shot. So I don't think that the absence of a difference in the actual intubation rates, it doesn't. It ultimately doesn't do anything from where I'm looking at the patient.
All right, understood. Anything else you guys want to add, or should we call it a day?
And I think that last point may be a good point to close with, which is that sometimes I get called by folks from the ER and they're like, hey, I have this patient. I haven't really managed to get them better. And they feel bad about it. And they may feel like obligated to intubate the patient. And my response is always just send them up. We're happy to spend the next 24 hours just like watching this patient nervously. So I feel like when there's a doubt about intubating these patients, like multidisciplinary collaboration is key. And oftentimes we're very happy to accept these patients and just do nothing.
That's great. And I should point out, because it speaks to the point you just made, Josh, these weren't ICU patients, which is weird. Now, that could be a difference in systems. Maybe their non-ICU, non-invasive ward is like as intense as our ICUs, but it also speaks again to, I just don't understand who these patients were, because These were not super sick patients in the ICU, though maybe they were all filled with COVID patients like Alex is mentioning, but that's strange to me as well. All right. I cannot thank you gentlemen enough. You've made me feel a little bit better about this paper, the two of you, so that's good. I always like when my views are shifted towards a more happy confluence with people smarter than myself, so I love that. And I can't wait to speak to both of you again.
It's a pleasure.
Yeah, thanks so much.
All right, that's a wrap.